Right, let's go to aortic stenosis. What are the
Yes.
causes of aortic stenosis?
So, well, broadly speaking, there are three causes for aortic stenosis. The first one being congenital, so you can have a unicuspid or bicuspid valve. The second is the most common, which is calcification. That typically occurs in elderly patients over the age of 70 and associated with risk factors such as hyperlipidemia and diabetes. And the third is from rheumatic heart disease, so post-inflammatory fibrotic changes. That typically occurs in the young.
What are the causes of sudden death in this condition?
That would be aortic dissection and myocardial infarction.
And how would you calculate coronary perfusion pressure?
So this is calculated by aortic diastolic pressure minus the left ventricular and diastolic pressure.
And how does stenosis occur?
This would occur in 4 stages. The first one would be lipid accumulation. The second one would be inflammation. The third then being calcification, and then the fourth being stenosis.
Right, and what's the pathophysiology of aortic stenosis, or the pathophysiological sequelae of aortic stenosis?
So the first thing that would happen is that you would get left ventricular hypertrophy. This is because the left ventricular resistance increases. And because of that, you get an increase in afterload because there's lack of blood leaving the left ventricle into the left atria. And therefore, the volume of blood increases in the left ventricle after systole. And then you subsequently get left ventricular hypertrophy. Because of that increase in afterload, you then over time get reduced elasticity of the left ventricle, and that reduces your coronary blood flow, and subsequently coronary perfusion pressure decreases. And then finally, you get decreasing preload, and that subsequently is because of the backflow pressures into the pulmonary vein, and therefore you move from left-hand sided heart failure into right-sided heart failure, and subsequently get cor pulmonale.
What are the complications of aortic stenosis?
So the complications of aortic stenosis would be, number one is you'd have a syncope. Well, typically it's patients would be asymptomatic, but you can get angina, you can get syncopal episodes, you can get dyspnea and shortness of breath, and other things that you would get complication-wise would be is increased risk of stroke and also venous thromboembolism.
What's the most likely cause of arm weakness following aortic valve endocarditis?
So this would be a thromboembolus that has subsequently caused a stroke and therefore unilateral arm weakness on the contralateral side to that of the stroke.
And which coagulation system is not affected by warfarin?
So this would be the intrinsic pathway because warfarin is a vitamin K antagonist and affects factors 2, 7, 9, and 10, protein S and protein C, and therefore that would be most as commonly associated with the extrinsic pathway.
What's the definition of a thrombus?
So the definition of a thrombus is a solid material that is formed by blood constituents such as platelets and fibrin.
And what is the definition of embolus?
So a embolus is a solid clot formation formed by the aggregation of platelets and direct relation to that of thromboxane A2.
What are the types of valves used in valve replacement, and what are the operations?
So the types of valves can be mechanical or tissue valve. So the other things that we typically can also do is a Ross procedure. So that involves taking a native valve that's functional and implanting it into the stenotic valve. You can also do minimally invasive procedures such as a balloon expansion procedure and also a trans-aortic valve replacement through the femoral artery.
Go on. Sorry, go on.
So the mechanical valve is typically long-lasting, it's durable, it requires lifelong anticoagulation on warfarin, and also there's typically associated with mechanical noise such as a large click. The tissue valve is something that is a human or graft from an animal. It's less durable, there's no anticoagulation involved, and patients typically have a lower risk of PTE.
What is the management of infective endocarditis in patients with metallic valve?
So here, given the fact that the patient has infection and infective endocarditis, the primary thing that would need to happen is the valve would need to be removed. This is because it would create a septic focus and also create a subsequent biofilm, and this can lead to a non-functioning valve.
What is the cause of microscopic branching hyphae on the removed metallic valve?
So given the fact that the patient has hyphae, I'd be worried about a fungal infection. So this would consist of either Candida, Aspergillus, or Tryptophyton. There are other fungal species as well that can cause hyphae.
You mentioned early the mechanism of action of warfarin, which is a
Yes.
vitamin K dependent. What are the complications of being on warfarin?
So the complications of being on warfarin are that there is a increased risk of bruising. So patients typically can have a minor trauma and can have increase in bruising. They will need regular blood tests to monitor their INR. Sometimes warfarin can be reversed acutely in traumatic situations, but INR would require monitoring, and it also can increase your risk of bleeding and VTE.
And how would you monitor warfarin?
So warfarin needs to be monitored on INR. If the patient has a metallic heart valve in this scenario, for example, INR would need to be between 2.5 and 3. It's typically done by INR nurses that take a regular blood test. Also, you need to look at coagulation, so APTT, prothrombin, and also other coagulation screening tools.
Very well. So you will notice that I haven't given you any feedback during this practice. I was timing you, and you finished basically 10 seconds early. So this is how tight the exam could be. All right. So I was timing you from the beginning. You started at basically when it was 20 minutes in the meeting, and now it's 28, 50 minutes. So obviously you do have about 9 minutes to get to the end of the scenario. I think well done. So that you finished it. This is considered as a long scenario, but try to think about it if it's melanoma that we did today. Very long scenario. So that's why it would be good to re-practice it at some point during the 13 mocks that you have. Let's go and feedback now. I think overall it went very well. I think the cause of aortic stenosis, you can make it shorter. So I would just say, as we agreed before, to the point, short and succinct. So you just say congenital, senile, and post-inflammatory. Congenital usually unique hospital by, and I personally like mentioning the headlines before going into the details. All right.
Yes.
So because literally the examiner might stop listening to you, which is and you works for your interest. So you say congenital, senile, post-inflammatory. Congenital could be unique hospital bypass. And senile is more than 70 years, and patient with risk factors such as diabetes and hyperlipidemia, and post-inflammatory between 30 and 70. And this is basically usually mitral valve, and that happens with patient with rheumatic heart disease. That's it. All right. So you can definitely make this shorter. Cause of sudden death, you mentioned it very well. You've mentioned this very well. Again, you've mentioned this very well. You can just go to the point as well. But I think you mentioned it very well. Again, this is, you talk longer. And I think you, again, use the headings. You just go for the headings first. So the pathophysiology can be divided into 3 points: left ventricular hypertrophy, increased myocardial load, and decreased preload. All right. And then you can go into the details of that, and you can explain whatever you want. And just make sure if you're taking longer than 40 seconds in any exam answer, that includes your communication procedure, whatever the part of the exam is, you're wrong. All right. So I wouldn't take more than 40 seconds in any question at any point. It doesn't matter how long the question is. Yes. Right? And probably the longest part will be the trauma cases in the acute.
I've seen that on your recordings for the S previously on the drive. People have taken to get through their A to E or mobilization of C-spinal. You just really take 3 or 4 minutes and they don't get through the end of the stem. So it really does have to be quite slick. Correct.
So go for the titles. Literally, the examiner might stop listening to you or might look for the keywords that you want to say. Complications, you could have said more than this, all right? I would start by, so the complication of aortic stenosis. So this is an outflow obstruction. So that means hypertension. That means left ventricular hypertrophy, because the outflow of the left ventricular hypertrophy, and this is congestive heart failure, can lead to ventricular tachycardia, can lead to mitral regurg, can lead to atrial fibrillation, and this can lead to cor pulmonale. If you think about it in that sequence, that'll be much easier to remember.
Well, because I mentioned it in the pathophysiology that it would naturally lead on, or they'd just tick. But clearly, you have to answer each question in sequel, right?
Examiner has a checklist that he has to fulfill. All right. So I'll ask you all the questions. Even if you try to speed up and answer the next question, it would actually work against you. All right. So try not to do that. You've given a good answer to this, no problem. A good answer to this. I think the whole warfarin part, you've answered it very well. Definition of a thrombus. I know everybody goes for this one. That's why I've written it, but I don't like it. I like the second one more. This is from Robbins. So it's a pathological formation of an intravascular blood clot during life.
Okay.
So this is the definition from Open's Pathology, right?
Yes.
So in the intravascular blood clot during life. It's an again, I like the second definition more than the first one. It's much more accurate. It's an intravascular mass that travels and occludes the downstream vessels, resulting in occlusion of that vessel. All right. They give the same meaning. You're just trying to be using a little bit more complex word, which they like, basically.
Yes.
I think the comparison, you could have made it slicker as well. So a tissue valve is noiseless, doesn't need warfarin. And again, I would say, I think I mentioned some of this feedback to one of your colleagues today. She was comparing between benign and malignant. And she kept saying benign would be this, malignant would be this, benign would be this. That was very boring. So here, tissue is noiseless, doesn't need warfarin, it's difficult to insert, less TE risk and lower bleeding risk. On the other side, it's the complete opposite. And you can stop here, right?
Yes.
I think you've answered this very well. Here, you could have mentioned all the examples, but to be honest, it's not really...
it's difficult. It's like when you ask for the gram-negative diplococci, and
which mentioned the gram-negative.
Yeah. Well, it's your famous city, I think, isn't it, from your YouTube videos from your home? But it would be Haemophilus, Brucella, Actinobacter, Moxarilla catarrhalis. I can't remember. There's always one that I can't remember.
I think you forget the most famous one, which is Neisseria meningitis, right?
Yes, that's the one.
So Neisseria should come. So it's a BNHA.
That's the one, BNHA. Yeah.
Good. I think overall it's a good performance. It's just a key point is the pathophysiology and just try to make it a little bit more slick. But otherwise, it went very well.